primarily here. How does this primary spread to multiple organs and form multiple secondary? So it can be via lymphatics, it can be via blood vessels, or it can be via cavities, that is transluminal route. So first understand the meaning of the three routes. The same thing is shown to you here in this diagram. You can draw this diagram in your exam, or you can draw this one also. Instead of drawing the complete body, you can show this is the tumor. This is the tumor. From the tumor, some of the cells get loosened and they enter in the blood. They enter in the blood, and via blood they enter in multiple organs. That you can show this is hematogenous route. Now from this tumor, some of the cells get loosened and they enter in lymphatics. You can see these are the lymphatics. These are lymphatics, and they spread to various organs via lymphatics. And transcelomic route is not shown here. So you can see. So for example, this is the main tumor, and these are the cells of the tumor. So first two routes are more common. Transcelomic is very rare. Okay. Now it can spread via blood. This is the blood vessel, and it can spread via lymphatic. So let me draw a lymphatic vessel. What do you mean by lymphatic vessel? How it is different from the blood vessel? What is blood vessel? What is lymphatic vessel? This is a lymphatic vessel. Now blood vessel is lined by the endothelial lining. You can see these are the endothelial cells. We all know that. The blood vessels are lined by endothelial lining. In a similar way, the lymphatics are also lined by endothelial lining. The only thing is that in the lymphatics, on the way multiple lymph nodes are coming. You can appreciate these are the lymph nodes. The lymph nodes are coming. In the blood vessel, we don't have lymph node. We have only cavity. We have a lumen with a cavity. Here we have a lumen along with the multiple lymph nodes on the way. These are known as regional lymph nodes. Now imagine the tumor cells getting loosened here and get entered here, and they are traveling here, traveling here, traveling here, and it will spread to multiple organs in the body. Here also it is spreading via here. It is losing some of the tumor cells and entering in the lymphatic. So whatever lymph nodes are coming on the way, they will get involved. They become metastatic. Whatever lymph nodes are coming on the way, they will get involved one by one. And here also it will spread to multiple organs. So here also it will spread to multiple organs, form multiple secondary. Here also it will spread to multiple organs, form the multiple secondary. But in blood vessel, the lymphatics are not involved. But in lymphatic route, along with the multiple organs are involved. Multiple secondaries are there. But the regional lymph nodes are also involved. Now you have to understand the first lymph node. The first lymph node which is there on the way, which is involved. The first lymph node is known as sentinel lymph node. In lymphatics, the first lymph node is known as sentinel lymph node. So first the sentinel lymph node is involved, then other one by one they are involved. They are involved in a sequence. It is not the thing that first this one will involve, then this one. No, it will be in the sequence, on the way, on the route, one by one. The one which is coming first is involved first. The one which is coming later is involved later. So the first lymph node is known as lymphatic, the sentinel lymph node. So that is the lymphatic spread. So out of the three spread, the first two spread are important. Lymphatic spread, hematogenous spread. Transcelomic is also there, but it's rare. So one by one, we will see the details of all three routes, one by one. You can get a short question on any of them. And if you are getting a long question, you have to write all with the diagrams. So let's start with the first route, lymphatic route. So okay, before coming on that, these two routes are important now. So which tumor spread by which route? Is it the tumor spread more by lymphatic route or tumor spread more by hematogenous route? So there is a rule. The rule is that carcinoma spread by lymphatic route and the sarcoma spread by hematogenous route. We know there are two types of malignant tumors. The malignant tumors of epithelial origin are carcinomas, and the malignant tumors of mesenchymal origin are sarcomas. So the carcinoma spread mostly by lymphatic routes, but exceptions are there. And sarcoma spread mostly by hematogenous route. That you have to learn the general rule. Carcinoma spread by lymphatic route and sarcoma spread by hematogenous or blood route. Make some mnemonic and learn it. So this is the basic rule. Now learn the three routes one by one. We will see the details. So the first one is the lymphatic. I told you regional lymph nodes are involved. Regional. So if there is a breast tumor, you can see this is the breast tumor. Can you see this is the breast tumor? So in the breast tumor, the axillary lymph nodes are involved. Can you see? So it will go and involve the axillary lymph nodes one by one by one. Axillary lymph nodes will be involved. Okay. Now if the tumor is present in the lung, this is a lung tumor. You can see the tumor is in the lung. So in case of lung tumor, the parahilar lymph nodes are involved. The lymph nodes which are present around the trachea and around the hilum. Parahilar and paratracheal. Hello everyone. In this session, we are going to cover an important topic, that is spread of tumor. So you usually benign tumor, if present, it's a malignant tumor. On hold. Within 10 minutes, the pathologist will inform is also there, but it's rare. So one by one, we will see the details of all three routes, one by one. You can tumor spread more by lymphatic route or tumor spread more by hematogenous route. So there is a rule. The rule is that carcinoma can you see this is the breast tumor? So in the breast is the lymphatic. I told you regional lymph nodes are involved. Regional. So if there is a breast tumor, you can see this is the breast tumor. Can you see this is the breast tumor? So in the breast tumor, the axillary lymph nodes are involved. Can you see? So it will go and involve the axillary lymph nodes one by one by one. Axillary lymph nodes will be involved. Okay. Now if the tumor is present in the lung, this is a lung tumor. You can see the tumor is in the lung. So in case of lung tumor, the parahilar lymph nodes are involved. The lymph nodes which are present around the trachea and around the hilum. Parahilar and paratracheal lymph nodes are involved. So regional lymph nodes are involved. In case of breast tumor, the regional lymph nodes is axillary. In case of lung tumor, the regional lymph nodes is parahilar or paratracheal. So whatever is the regional lymph node that is involved. I'm saying it again. For example, this is the tumor, and any tumor. Maybe this is the breast tumor, maybe this is the lung tumor. So this is the tumor. Now this tumor, this is the lymphatic for that tumor. So these are the lymph nodes. These are the lymph nodes. So tumor cells will get looser, anchored in the lymph node like this. Some of the tumor cells, the main tumor, primary tumor cells, and they will involve the lymph nodes one by one. They will travel, they will involve the regional lymph nodes one by one. So if this is breast tumor, so all these lymph nodes are axillary lymph nodes. If this is the lung, so all these lymph nodes are parahilar or paratracheal lymph nodes. In any case, the first lymph node is sentinel lymph node. I hope you got it. The first lymph node is known as sentinel lymph node. You see, why sentinel lymph node you are insisting so much and why it is important? For example, there is a lady who is having a breast nodule. She is having a breast mass in her one of the breast. So she is a lady, she is a female, for example. Let's quote an example and let me tell you the importance of sentinel lymph node. And she is coming to me, and I'm a doctor, and she is complaining, doctor, I'm feeling a mass in my breast, in one of the breast. So what I will do, being a doctor, the first thing I should do is the biopsy. I have done a biopsy of this mass. In the biopsy, I will look for anaplasia. The features of anaplasia are absent, it's a benign tumor. If present, it's a malignant tumor. Unfortunately, I found on the biopsy the features of anaplasia are present. I mean, it's a malignant tumor. So I inform the lady that it's a malignant tumor. We have to operate it immediately. We have to operate it. We have to take the tumor out. After that, I will give you chemotherapy. We will give you radiotherapy, and we will give the targeted therapy, hormonal therapy, all of them. But the first thing, we have to operate it. So the lady is convinced and she is ready for the operation. She is ready for the surgery in which we are going to remove this tumor from her body. So what surgery we will perform? You will either remove the lump only, that is known as lumpectomy, or remove the complete breast if the lump is very big, that is known as mastectomy. So depending, it's the call, depending on the tumor size, whether we perform lumpectomy or mastectomy, that is we are going to remove the primary tumor, okay, with the help of the surgery. But along with that, this is not the only surgery. Will we remove this axillary lymph nodes? Yes or no? This is a bunch of axillary lymph nodes. So yes. So we will give one scar over the breast and remove the tumor. We will give another scar in the axilla and remove the axillary lymph nodes. So why it is necessary to, we always remove the axillary lymph nodes along with the main tumor. Why? Because we know it's a carcinoma. Breast carcinoma is a carcinoma, and carcinoma spread via lymphatics. So if we are removing only the primary tumor and we are not removing the lymphatics, so maybe the primary tumor have already spread it to the lymphatics, and lymphatics are involved, and we are leaving the lymphatics in the body only. And via this lymphatic, it will spread to multiple organs, and the same lady, even after surgery, we have removed the primary tumor. Even after surgery, she will present with mass. So there is no use of the surgery. We cannot afford that. We cannot put this lady to have the mass in future. So that's why we always give 2 incisions during surgery. So before the surgery only, you have to consult your patient that we are going to give you 2 incisions. The first incision will be on your breast, in which we will remove your primary tumor, we will remove your tumor from the breast. Either lumpectomy, mastectomy, whatever. Okay. And the second incision we will give you the axillary. Along with your tumor, we are going to remove your axillary lymph nodes also. So she may be asking you, I'm having tumor in the breast. So I understood that you are.
तो है
रिकॉर्ड करेगा
न्यू लाइव चल रहा है लेकिन 0 व्यूअर्स है
तो लाइव से क्या कर रहा है
ऐसे ही है अरे प्रमोट का अब क्या देख रहे हैं
स्टेटस देखना सबका
हाँ
खाली हैप्पी मदर्स डे लगाया हुआ है
एक रूम फ्रेशनर हम लोग खरीद लेंगे
खरीदना पड़ेगा
With my breast, you are removing the tumor of my breast. But why you are removing the axilla? Why? So you have to explain it that this tumor have a tendency to spread via the axillary lymph nodes. So if you remove only your tumor and don't remove your axillary lymph nodes, we are leaving a portion of the tumor in your body, and in future you can present with the mass. You cannot perform that. So we have to remove the axillary lymph nodes. So the next question that can arise in your mind or in this patient's mind is the axillary lymph nodes the vestigial organ? So what if you are removing it? So what side effect or adverse effect can I have after removal of the lymph nodes? What's the function of the lymph nodes? The function of the lymph nodes is to prevent bleeding. To prevent edema. Now you are removing the lymph nodes. So this lady can.
चल रहा है रोज बोला
In this
यूज किया था
ना
चार्ज किया था इसको
चार अच्छा से नहीं हुआ अरे
वाइब्रेटर का ऑफ
लेक्चर ही नहीं चल रहा बस ये भी नहीं चाहता टाइप की हम पढ़ाई करें डाउनलोड हो गया हुआ प्ले नहीं हो रहा
session, we are going to discuss the ultra important topic that is benign.
फुलजासन सिंह
Benign versus malignant tumor. So you have to differentiate the benign tumors and the malignant tumors. Hello everyone. In this
मैं वो कहाँ गया बस जूनियर वर्ष था
बस डोंट नो बॉस
हमें चाय लगा दो
मैंने कुछ नहीं किया
हमें चाय निकालते नहीं ऐसा भी वाला
वो रहा हमारा रखा हुआ
Hello everyone. In this session, we are going to cover an important topic that is spread of tumor. So you usually get a long question in your university exams on that. So if you are getting a long question on spread of tumors, you have to write all three ways of spread of tumors. That is lymphatic,
Bomboclat.
actinous,
What
and
is this
plasmodium.
bomboclat?
Sometimes you get a short question on each of that, so you have to write that question. But sometimes you get a long question on the method or the mechanism of the metastasis in which you have to write all the steps. So we are going to cover everything in this session, so let's start it. The topic that is spread of tumor metastasis. Let's start it. First of all, I will let you know the introduction. What do you mean by what can you see? So it will go and involve the axillary lymph nodes one by one. Axillary lymph nodes will be involved. Okay. Now, if the tumor is present in the lung, this is a lung tumor. You can see the tumor is in the lung. So, in case of lung tumor, the parahilar lymph nodes are involved. The lymph nodes which are present around the trachea and around the hilum, parahilar and paratracheal lymph nodes are involved. So, regional lymph nodes.
What bomboclat
for breast tumor,
is
the
this?
regional lymph nodes is axillary. In case of lung tumor, the regional lymph nodes is parahilar or paratracheal. So, whatever is the regional lymph node that is involved. I am saying it again. For example, this is the tumor, any tumor. Maybe this is the breast tumor, maybe this is the lung tumor. So this is the tumor. Now this tumor, this is the lymphatic for that tumor. So these are the lymph nodes. These are the lymph nodes. So tumor cells will get loosened, enter the lymph node like this. Some of the tumor cells, the main tumor, primary tumor cells, and they will involve the lymph nodes one by one. They will travel. They will involve the regional lymph nodes one by one. So if this is breast, if this is breast tumor, so all these lymph nodes are having. Let's go to an example. tumor, we are going to remove your axillary lymph nodes, the tumor in your body, and in future you can present with the match. We cannot report that. So we have to remove the axillary lymph nodes. Because the edema of this hand, the complete hand can have, the corresponding hand of that side can have edema, the lymphodema after the surgery. Now this lymphodema is the, you can say, a comorbidity of the surgery. So there are two options. If you don't remove the lymph node, she can present with mets in future and she can die. And if you remove it, she can have lymphodema in future. But we can manage lymphodema, we cannot manage mets. So you, out of the two options, the lymphodema is a better version. So you have to consult the lady that in future, after the surgery, you can have a comorbidity that is lymphedema, but we can manage that. Because it is a benign disease and we can manage that. But if you leave the lymph node, you don't have lymphedema, but you can have the mets. You cannot afford that, you can die from that. And you can already be entering in the stage 4 cancer, we cannot afford that. Got my point? But having this comorbidity for throughout the life, lymphedema is not a good thing. So she may ask you, doctor, is there a way to find during the surgery if my lymph nodes are involved, then you definitely remove it. But what if my lymph nodes are not involved? Unnecessarily you are removing it and I will have lymphedema in future as a comorbidity. So can you confirm that my lymph node are involved or not involved? You definitely remove my tumor. I don't have any problem with that. The lady is saying, the patient is saying to you, doctor, remove my tumor. Of course, I'm having a tumor in the breast, but you have to remove it. But what about the lymph node? Are you sure the lymph nodes are involved? If involved, you just remove it. But what if they are not involved? Why unnecessarily you are going to remove it? So is there a way during the surgery only can you plan it? Well, can you decide whether the lymph nodes are involved or not involved? So yes, during the surgery, intraoperatively, you can decide it with the help of a technique known as frozen section. What do you mean by frozen section? Have you heard about it? Frozen section, a pathologist is there during the surgery. So during the surgery, the surgeon take out the first lymph node, sentinel lymph node, and handed over it to the pathologist. The pathologist will make a section out of it and report within 10 minutes, 10 to 15 minutes to the surgeon. And during 10 to 15 minutes, the patient is on hold. The patient is in anesthesia only, the patient is on hold. Within 10 minutes, the pathologist will inform the surgeon whether the sentinel lymph node is involved or not involved. If it is involved, the surgeon is going to continue the surgery to remove all of the lymph nodes. Because the first is involved, because they are all involved. And if the pathologist is saying to surgeon, no,
What
the sentinel
type of
59% कंटिन्यूटी पढ़ा रही है बॉस। अगर माने आपका ब्रेस्ट में ट्यूमर हो गया आपके तो ब्रेस्ट में ट्यूमर है तो ट्यूमर क्या मेटास्टेसिस भी शो करता है, मेटास्टेसिस मतलब वहाँ से फैल भी सकता है और जनरली या तो ब्लड या तो लिम्फ के थ्रू फैलता है। ब्रेस्ट के बगल में आपका एक्सियल लिम्फ नोड है, तो हो सकता है वहाँ भी चला गया हो। तो जनरली जो ब्रेस्ट में से ट्यूमर निकालते हैं उन्होंने लिम्फ नोड भी निकाल देते हैं कि फर्दर कोई फ्यूचर में कैंसर वापस ना आ जाए, ठीक है। तो जब ऑब्वियसली जब ब्रेस्ट का सर्जरी कर रहे हैं उसी समय लिम्फ नोड का सर्जरी करेंगे। मान लीजिए मोस्ट ऑफ केस में तो चले जाता है लिम्फ नोड में, लेकिन अगर लिम्फ नोड में नहीं गया होगा, अब फालतू का लिम्फ नोड भी निकाल दिए, अपना हाथ स्वेल कर जाएगा क्योंकि लिम्फ यहाँ से ड्रेन कर ही नहीं रहा, लिम्फ नोड है ही नहीं। इसलिए जानते क्या करते हैं, उस लिम्फ नोड में बहुत सारा लिम्फ नोड होता है ना, जो सबसे पहला लिम्फ नोड होता है उसको कहते हैं सेंशियल लिम्फ नोड। हाँ नहीं, सेंटिनल लिम्फ नोड। तो सेंटिनल लिम्फ नोड को उसी समय जब ब्रेस्ट का सर्जरी कर दिए, अब सेंटिनल लिम्फ नोड को निकाले, वो दे दिए पैथोलॉजिस्ट को 10 से 15 मिनट बताओ कि इसमें कैंसर गया है कि नहीं गया है। वो 10 से 15 मिनट अपना पैथोलॉजिकल टेस्ट किया, बताएगा कि हाँ इसमें कार्सिनोमा है या नहीं है। अगर है तो लिम्फ नोड को हटा देगा, नहीं है तो छोड़ देगा, वापस देगा। कितना बढ़िया चीज है।
ब्रेस्ट कैंसर मेरा तो नहीं हो रहा,
हम करवा देंगे दवा लगा के।
is not involved. If the first is not involved, no one else is involved. So we will leave the patient, you just suture it, and we will not further remove the lymph nodes. So by doing frozen section, we can take a call during the surgery only that whether
तो ये खाना पड़ेगा।
not remove the lymph nodes. So the main role in the frozen section.
कौन सा सैमसंग वाला फाइल है क्या?
So I'm operating on this lady. For example, this is the lady and the lady is an anesthesia, and for example, I am the surgeon who is operating on her. Okay, she is having a lesion in her breast, a mass in her breast. Okay, so this is the mass in the breast, you can see. So being a surgeon, I have already operated it, I have taken it out. I have performed the lumpectomy or mastectomy and taken it out with clean margins. Okay, now I have to take a call. Being a good oncosurgeon, I have to take a call that whether I have to remove the axillary lymph nodes, yes or no. So I'm having a pathologist available with me. The pathologist is capable of doing the Coulson's action. Okay, so what I will do, I will take the first lymph node out, sentinel lymph node. This is sentinel lymph node, and hand over to the pathologist and ask the pathologist to report it immediately. So the pathologist will take 10 to 15 minutes, and within 10 to 15 minutes, the pathologist is going to inform me that, doctor, either this is involved or this is not involved. If the pathologist is saying it is involved, I will remove all of them. If the pathologist is saying no, it's not involved, I will leave that. So we are taking a call during the surgery. Now you may be thinking how the surgeon come to know that out of all these lymph nodes, this lymph node is sentinel to hand over to the pathologist. How am I come to know that out of a bunch? So the lymph nodes are in the form of a bunch. Are you understanding? It's a bunch of lymph nodes. Out of the bunch of the lymph nodes, how I will come to know that it is a sentinel lymph node, the first lymph node? So we use dye. We will inject the dye in the lymphatics. Can you see here is the lymphatic? So the lymphatic coming out of the breast, I will inject the dye in that. So dye will highlight the lymph node one by one. So the dye highlighting the first lymph node is sentinel lymph node. See, have a look. Let me show you. Here can see here, listen. This is the primary tumor present in the breast. So this is the lymphatic. Some of the tumor cells are coming out of the lymphatic. So this is the first lymph node. This is what is sentinel. This is the second tier. This is the third tier. But the first lymph node which is involved is sentinel. I'm interested in that. So can I inject the dye? Listen. See, I'm injecting the dye. Have a look on the video. So you can see this is the primary tumor. This is the primary tumor. Now this is the first lymph node which is involved. And after that others are involved. So the dye is moving to the first lymph node. The dye is moving to the first lymph node. The first lymph node is involved. After that particular lymph node. So with the help of the dye we can do that. So I will dissect this one and hand over to the pathologist and ask the pathologist to report whether it is involved or not involved. If it is involved, I am going to remove it. If it is not involved, I am not going to remove. Okay, I will leave for this. So it is only in sequence they will go one. I hope you are getting it. Say yes if you have got it. So that is the thing. Now this is the lymph node. In the diagram of a lymph node, we have a capsule. This is the capsule. And we have the follicles. You know what are the follicles? The lymphocytes are arranged in the form of the follicles. These are the small follicles. The lymphocyte sites are arranged in the form of the follicles. Just below the capsule, we have the sinusoids, the blood capillaries which are known as sinusoids. Now, just suppose if this lymph node is involved, this is the lymph node, for example, it is involved. This is the first lymph node which is coming in the way. So, these are the tumor cells, these which are known as sinusoids. Lymphocyte sites are cool. This is the capsule. They will go one by one. And report whether it is involved or after that, multiple others are involved. And after that, others are involved. Inject the dye. Listen, see, I'm injecting the dye. Have a look on the video. So, you can see this is the primary tumor. This is the primary tumor. Now, this is the first lymph node which is involved. And after that, others are involved. So, the dye is moving to the first lymph node. The dye is moving to the first lymph node. The first lymph node, you can see this is the first lymph node which is involved. After that, multiple others are also involved. So with the help of the dye, we can do that. So I will dissect this one and hand over to the pathologist and ask the pathologist to report whether it is involved or not involved. If it is involved, I am going to remove it. If it is not involved, I am not going to remove it. Okay, I will leave for this. So it is only in sequence they will go one by one. I hope you are getting it. Say yes if you have got it. So that is the thing. Now this is the lymph node. In the diagram of the lymph node, we have a capsule. This is the capsule. And we have the follicles. You know what are the follicles? The lymphocytes are arranged in the form of the follicles. These are the small follicles. The lymphocyte sites are arranged in the form of the follicles. Just below the capsule, we have the sinusoids, the blood capillaries which are known as sinusoids. Now just suppose if this lymph node is involved. This is the lymph node, for example, it is involved. This is the first lymph node which is coming in the way. So these are the tumor cells. They are coming in the lymphatics. So in a lymph node, where does they involve? They involve the follicle. They involve the capsule. No, they don't involve the follicle first. They don't involve the cortex. They don't involve the medulla. Just below the capsule, they involve the subcapsular sinus. So the first thing they involve is the subcapsular sinus. What we call it? Subcapsular sinus. So you got it. So in the diagram also you can see it here. This is the capsule, and just below the capsule, I want to highlight you. This is the capsule. Just below the capsule, please get highlighted the malignant tumor cells. You see, these are the tumor cells. They are going to the follicles later on. They will go to the cortex and medulla later on. But the first thing is the subcapsular sinus. So in the lymph node, the first thing involved is the subcapsular sinus. You can see the first subcapsular sinus. One more thing you have to learn here is the Virchow lymph node. What is Virchow lymph node? Now, throughout the body, the lymphatics of head, neck, chest, abdomen, pelvis, lower extremities, they all drain in thoracic tube. ultimately the lymphatics of all these places they will drain in the blood via thoracic duct, and just before the thoracic duct there is a lymph node, that is left supraclavicular lymph node. Can you see? This is the left side. So left supraclavicular, just above the clavicle, you can palpate. This is the clavicle. Just above the clavicle, you can palpate this space, this left supraclavicular space, and in this there is a lymph node. So just before the thoracic duct, this is the lymph node. So all the drainage throughout the body, the lymphatic drainage want to go in the thoracic duct, but before thoracic duct they drain in this lymph node. It is known as spiritual lymph node. So sometimes if there is a malignancy anywhere in the body, anywhere in the abdominal organs like stomach, like pancreas, liver, anywhere is the malignancy, intestine, esophagus, or lower limb, and it is coming via lymphatics. And before draining the thoracic duct, the lymphatics are coming in the left supraclavicular lymph node. So this lymph node will get enlarged. You see the left supraclavicular lymph node will get enlarged. This is known as spiritual lymph node. So sometimes patient may come to you that, doctor, I am having a mass over here, no other complaint. So that it is presenting a inside malignancy, hidden malignancy in that patient. Sometimes the malignancy has symptoms later on. It is
malignancy was cancer ही हुआ ना?
hidden. Maybe this patient can have a cancer of the stomach, intestine, esophagus, any of the organ, but it is not presenting here. The patient is presented with metastasis in the virtual lymph node. So any patient coming to your clinic with a complaint, I am having a mass in the left supraclavicular lymph node. So always first biopsy that and screen the malignancy in entire body. Do the screening for that. So that is the virtual lymph node. Virtual lymph node is the left supraclavicular lymph node, and it is the lymph node just before the thoracic duct. And node, just before the thoracic duct. So sometimes it gets enhanced. That is virtual lymph node. So we have seen, I am teaching you metastasis. I am teaching you the 3 roots of metastasis. 1, 2, 3. 3 roots of metastasis. We have already seen lymphatic root, and now we'll the metastasis. Just before the thoracic duct and node, just before the thoracic duct. So sometimes it gets enhanced. That is virtual lymph node. So we have seen, I am teaching you metastasis. I am teaching you the 3 roots of metastasis. 1, 2, 3. 3 roots of metastasis. We have already seen lymphatic root, and now we'll continue with the hematogenous root and transthelomic root. In the lymphatics, what important points we have seen? In the lymphatic roots, we have seen that carcinoma spread via lymphatic root, sarcomas spread via hematogenous root. In the carcinomas, they spread via lymphatic root, so regional lymph nodes are important. In the breast, the regional lymph nodes are excellent. In the lung, the regional lymph nodes are parahilar, paratracheal lymph nodes. The first lymph node is sentinel lymph node, and sentinel lymph nodes are important in many surgeries for frozen section. We do the dye, we inject the dye. The first lymph node via lymphatic root, so regional lymph nodes are important. Spread via lymphatic root. Sarcoma spread via hematogenous root. In the carcinomas, they spread via lymphatic root, so regional lymph nodes are important. In the breast, the regional lymph nodes are excellent. In the lung, the regional lymph nodes are parahilar, paratracheal lymph nodes. The first lymph node is sentinel lymph node, and sentinel lymph nodes are important in many surgeries for frozen section. We do the dye, we inject the dye during frozen section, and we take out this first sentinel lymph node and do the frozen section and take a call during the surgery. That is important. In the lymph node, the first portion which is involved, inject the dye during frozen section, and we take out this first sentinel lymph node and do the and take a call during the surgery. That is important. In the lymph node, the first portion which is involved is subcapsular sinus. Just below the capsule, subcapsular sinus is involved. And there is a term which is known as virtual lymph node. I have explained you that also. What does it mean? So whenever any patient is coming with a virtual lymph node, always screen for the hidden malignancy. Never take it lightly. These are the important points you have to write in your exam regarding the lymphatic root, and you get many MCQs. So say to summarize lymphatic root. Carcinoma spread via lymphatic root. So via lymphatic root, the regional lymph nodes are involved. The regional lymph nodes are involved, other lymph nodes are not involved. First lymph node is sentinel lymph node, and there is the importance of frozen section of sentinel lymph node via dye, with the help of dye. Inner lymph node, is it the cortex or medulla? Which portion is involved? Major cortex or medulla? It's the subcapsular sinus which is involved. And what about the virtual lymph node? It is the left supraclavicular lymph node that sometimes it is the only symptom the patient has, and is present a hidden lymph. So you have to write all these points in your exam, explaining, drawing well-labeled diagram if the lymphatic spread is coming in your exam. So let's come on the next spread, that is hematogenous spread. So let's come on the next spread. The next spread is the hematogenous spread. I told you, sarcoma spread via hematogenous spread. Carcinoma spread via sarcoma spread via hematogenous spread. Say this is a tumor. This is the tumor, the primary tumor. And these are the cells of the tumor. Okay, let's say these are the cells of the tumor. Okay, now see, this is a artery supplying pure blood, oxygenated blood to this tumor or this organ, and this is a vein carrying the impure blood, deoxygenated blood away from the organ. Now I am saying hematogenous route. I am saying hematogenous route. I mean the blood spread. So the tumor cells are spreading via blood. So my question to you, tumor cells spread via artery or vein? The tumor cell will enter which one? More common. Arteries are involved, more common or vein. So here the tumor cells will dissociate. They will loosen and dissociate. Will they enter in the artery and spread in multiple organs, or will they enter in the vein or they spread in multiple organs? Use your common sense and tell me. Have a guess. Have a guess. So can you tell me which one is more commonly involved? Is it artery or vein? So of course, answer is vein, not artery. Answer is vein. Why? Because vein have thin wall. Vein have thin wall. Arteries have very thick wall. We know that. I guess every student knows that. So when the tumor cells want to penetrate from the main tumor, so what is more easy for the tumor cell? To penetrate the vein which is having thin wall, or to penetrate the artery which is having thick wall? So tumor cells don't penetrate the artery because the resistance is more, because they are having thick wall, but they penetrate the vein more easily. So here, out of the artery and vein, have a look on the thickness of their wall. Have a look on the thickness of the artery, the wall of the artery, and have a look on the thickness of the vein, the wall of the vein. You are getting my point? So veins are more commonly involved than arteries because of the thinner walls. They have thinner walls. So that is the hematus. That is the hematus, which veins are more commonly involved than arteries because of having thin walls. So first thing you have to learn that. Now listen, here are all veins will go. All veins will go. You know all the GIT veins. You know the GIT veins, stomach, vein, pancreas, intestine, other organs. All the GIT organs, the vein of all the GIT organs. Let me show you just a second. The vein of all GIT organs, you can see. Veins of all GIT organs, they drain in the liver or in the kidney. So imagine if someone is having malignancy in any of the GIT. Someone is having malignancy in the stomach, or malignancy in the spleen, malignancy in the pancreas, malignancy in the liver, malignancy in the intestine. So any organ malignancy. Someone is having malignancy anywhere in the GIT. So the tumor cells will go in the vein. So here the tumor cells are moving in the veins like this. The tumor cells will go in the veins like this, veins like this. So all the veins of the GIT will go in the portal vein, and via portal vein is first secondary to form the liver. So liver is the most common organ involved in case of sarcoma. So if the primary malignancy is sarcoma, it's spread by a blood, it's spread by a vein, and veins of GIT drain in the liver. So it is the reason. This is the portal vein. That's why liver is the most common organ where secondary is. Secondary can be found anywhere in the body. Multiple secondaries can be found, but the most common organ which is involved is secondary liver, because liver is getting blood from the vein, venous blood from the entire GIT. So entire GIT organ they drain in the liver. So if there is a malignancy in any of the GIT organ, maybe it is because maybe stomach, maybe intestine, pancreas, spleen, so it is spread by a portal vein to the liver. So liver is the most common and the first organ which is involved in GIT. So yeah, so it is for the GIT organ. But what about other organ? Imagine any other organ, not GIT organ, any other organ having malignancy. Any other organ, for example, the brain is having malignancy, the heart is having malignancy, or any other organ, the bones are having malignancy. There are many organs, muscles have malignancy. Any other organ, not GIT organ having malignancy. So it is spreading, it is a sarcoma, it is spreading via hematic fluid, the blood. So here the tumor cells will go in the vein, and all the veins of all organs they drain into the superior inferior vena cava. So via superior inferior vena cava, the tumor cells will go in the right ventricle. From the right ventricle, they will go in the right ventricle. From the right ventricle, they will go in pulmonary artery, and they will go in the secondary vena. So most common organ which is involved in organ other than GIT is the liver. So most common organ which is involved in organ, if there is the primary in the organ other than GIT, so the most common is the liver. So if there is a primary tumor in the GIT, you tell me where is the second. If there is a primary tumor in any other organ than GIT, any other organ than GIT, not GIT, but any other organ than GIT, it is a primary, then you tell me the most common organ in which the secondary is. So in case of GIT, the secondaries are most common in the liver. The reason is portal circulation. And in case of any other organ, the secondary is most common in the lung. The reason is caudal circulation. This is known as portal circulation because of the portal vein. All the GIT organs drain via portal vein to the lung, and all other organs drain via superior inferior vena cava. It is known as caudal circulation. Via caudal circulation to the lung. So via caudal circulation to the right side of the heart, right auricle, right ventricle, and left to the lung. So most common organ which is involved in secondary via blood route is liver followed by liver followed by which happens in liver due to portal drainage and lung due to caudal drainage. This is portal drainage, this is caudal drainage. I hope you are getting. So that is got my point. So if there is a primary in GIT, any organ of GIT, there is a secondary. And if there is a primary in any other organ than GIT, not GIT, any other organ, there is a secondary. Tell me where is the secondary here and where is the secondary here. Here the secondary is the liver, and here the secondary is the liver. Okay, here the secondary is the liver because of portal circulation, portal vein, and here the secondary is the lung because of caudal vein, the superior inferior vena cava. So that is the caudal vein. And veins are more commonly involved. And out of the liver and lung, which is more common, if we compare the liver to the lung, so liver is commonly involved. So most commonly organ involved in secondary is liver, lung. So this is the complete thing you have to write in the hematic history. So till now, out of 3 routes to one, we have seen the lymphatic route, we have seen the hematic history. Coming on the third and the last route, that is troxin. In the troxin spread, there are 3 types of it. One by one we will see. Most commonly it is through cavity. You see, this is the primary tumor. This is the primary tumor. It is an ending of the organ, and these are the cells of the primary tumor. They are not going in the lymphatics. They are not spreading by no, they are not losing and going to the lymphatics. Lymphatic spread is one. They are not going in the blood also. I mean, they are not going in the veins also. So they are not spreading by the veins. neither they are going in the lymphatics nor they are going in the blood vessels. No lymphatic spread, no lymphatic spread, but it is spreading to other organs. So how does it spread to other organs? You are saying it is not entering in the lymphatics, it is not entering in the blood. Then how does it spread to multiple other organs? So here tumor cells are shed freely in the cavity. They are shed freely in the cavity, the peritoneal cavity and the abdominal cavity, and via cavity it spread to multiple organs. So this spread is transluminal. In the transluminal it is through the cavity. It is through the cavity, the natural open field. It is not through lymphatic, not through blood vessels, not artery, not vein, nor lymphatic. It is through the cavity. The best example which I can quote is a female. Let me show you a female. She is a female. It happens in females because she is a female. And unfortunately, she is having a cancer of the stomach. A cancer of the stomach. I'm just showing a rough diagram. So let's show you the stomach. So she is having a primary malignancy in the stomach. This is the primary malignancy in the stomach. And these are the ovaries of the two ovaries. So here, the stomach, the tumor cells of the stomach, they are not going in the lymphatic, they are not going in the blood vessels. They are shed freely in the cavity. The abdominal cavity, and they will float here and there in the cavity. And that floating may involve both the ovaries. In the both the ovaries, there are secondary. So total 3 tumors are there. One primary, two secondary. You can see one primary tumor and two secondary tumors. This is known as Krukenberg syndrome. Krukenberg syndrome, the patient presents, the female patient presents with 3 tumors. One primary and 2 secondaries. What is the one primary? One primary, the patient is having a tumor in the stomach, the gastric carcinoma. And the 2 secondaries in both the ovaries, the patient is present. So this is known as Krukenberg syndrome because of the word primary. So that is the best example in which the tumor is spread via cavity. It is not through lymphatic, not through blood vessels, it is via cavity. Via open cavity, it is the best example of transluminal. It is Krukenberg tumor, in which the primary tumor is in the stomach and 2 secondaries are in the both ovaries. See, this is the stomach. The primary tumor is in the stomach and it is spreading. Here only one ovary is shown to you and both the ovaries. You can see this is both ovaries of this patient. In your vision, one of the ovaries is one of the ovaries is the uterus. The uterus is very small and both ovaries are large because both the ovaries is having mass inside because of the primary. The primary is coming from the stomach. So that is the Krukenberg syndrome. That is the first way in transluminal. In transluminal, there are 3 routes. The first is via cavity. The second is via theater. For example, someone is having a brain tumor or spinal cord tumor. So while either the patient is having the tumor in the meninges of the brain or spinal cord or epithelioma, so tumor cells are shed in the theater. And via theater, they move here and there. So for example, the patient is having a tumor over here in the meninges. So tumor cells are shedded into the theater, and via theater, they carry away other side, and the secondary tumors are formed in the annular as in the spinal cord. In annular as in the central nervous system. From the point, for example, this is the brain and this is the spinal cord. Central nervous system. They are surrounded by 3 meninges. So the innermost is the pia meter, the middle one is the arachnoid, and the outermost one is the tumor. Now the space between the pia meter and arachnoid is known as subarachnoid space, and it contains the skeleton. So here this is the skeleton. For example, we all know subarachnoid space contains the skeleton. This is the entire skeleton flowing entirely in the central nervous system in the brain and the spinal cord. For example, someone is having a tumor over here. So tumor cells are shed in the skeleton, and via skeleton they are carried away, and they form secondary or multiple secondary at distant sites. So this is the primary tumor and this is the secondary tumor, both of them are distant. The spread is via CSF. It is also known as transluminal. Got my point? So it is not through the artery, it is not through the vein, it is not through the lymphatic tissue, it is not through lymphatic, it is not through cavity, it is through CSF. It is through CSF. So it is spreading from one side to another. The same thing is shown to you in this. And it's important by CSF. And third is implantation. For example, there is a patient and there is a surgeon who is operating this patient. The surgeon is operating this patient. Got it? Now the patient is having a oral cancer. For example, this is the cancer present in the oral cavity of this patient. And surgeon is operating. This is the scalpel, the surgeon is cutting the tumor. So this is the blade of the scalpel. This is the blade of the scalpel. The surgeon is cutting the tumor. Now the surgeon is not sterilizing the scalpel, and then the scalpel is having tumor cells on that. This is the tumor cells present on the scalpel. Now the same scalpel surgeon is cutting something else. Something else accordingly required for surgery. So the surgeon is transmitting the tumor cells via one point to another via one. The tumor cells get implanted here and moving into the tissue. So via scalpel of the surgeon, the tumor cells get. It is not through lymphatic, it is transmitted. It is not through CSF. It is not through blood. It is the scalpel of the surgeon which is transmitting the tumor cells from one side to another in the same patient. So it can be implantation. Surgeon scalpel, needles, sutures, but it is rare, very rare. I taught you the 3 roots of breast. First is implanted, second is microvenous, that is blood, and third is transluminal, which is for the oxygen. This is what happened. Now if you are getting a long question, write everything. If you are getting a short question, write the solution. Now in the lymphatics, what is the important points we have seen? We have seen the carcinomas spread via lymphatic and sarcomas spread via hepatogenous, and transluminal is the rare. The first thing we have done. Now here the regional lymph nodes are here. In breast it's axillary, in the lung it's parahilar, it's like that. So regional lymph nodes are important. The first lymph node is sentinel lymph node. For sentinel lymph node we injected dye and take out the sentinel lymph node, and it is required for frozen section so that we can avoid the comorbidity condition of the patient. Even in the best example in this spiritual lymph. What is spiritual lymph node? The left supraclavicular lymph node. Sometimes it is the first. So write everything about that. Draw the proper diagrams. Coming on hematogenous route, sarcoma spread via hematogenous route. You already seen that. And here veins are more commonly involved than arteries because veins have thin involved, arteries have thin involved. Now since veins are involved now, the most common organ involved is liver because of total circulation, and second most common organ involved is lung because of bowel circulation. You can understand total vein and proper vein. So that is veins. So that is PMC. In GIT malignancies, the liver is the organ which is first metastasis, and in other malignancy apart from GIT, lung is the organ which is shown first. So that is the key. Coming on transthelomic route, here we have discussed three groups. The first through cavity. The best example is through you have to draw the diagram and write down. In which we may have one primary tumor in the stomach and two secondary tumors in the bone. The second we have seen via CSF. And the third, the scalpel of the surgeon, that is the plantation. So that is the summary. I have summarized that this is how you retain and learn. Okay, so that is the now after that, one more thing before ending it, I would like to tell you the weekend group understanding. Tell me, I taught you the three ways now, the three routes. Lymphatic, hematogenous, and transthelomic. I want you to learn the steps of hematogenous. Tell me the 8 steps. There are 8 steps. I will show you all 8 in one. First, take a diagram, then I will show you a video also. The video also I will summarize all the 8 steps. Can you see this diagram? In this diagram, first let me help you in understanding the diagram. Can you see this is the primary tumor? Okay, have a look. This is the primary tumor and these are the cells of the tumor. So now as the primary tumor wants to spread multiple other organ and organs, it can be via blood. You can see this is the blood. The thing which is present between the tumor and the blood vessel is extracellular matrix. Can you see this is ECM? Extracellular matrix. It is the connecting tissue between the tumor and the blood vessel. So what we have to do? How it will happen? 8 steps. There are 4 diagrams, each showing 2 steps. 2, 2, 2, 2. So 2 steps here, 2 here, 2 here, 2 here, total 8 steps. So first the tumor cell, from out of all the tumor cells, the primary tumor cell is the primary tumor. Out of all of them, some of them become active. And they show the androgen. For example, here this tumor cell, a clone of tumor cell, a few tumor cells, they become highly aggressive. They become because they are going to show the vaccine. Not all tumor cells, the primary tumor cells will do the vaccine. A few of them. So first step they will become aggressive. A few clone, a little bit clone out of the primary tumor will become highly aggressive. After they become aggressive, they lose the from them. So they will become loose. How they will become loose, I will tell you. They will lose from others. They will loosening is the second step. They will lose from others. After becoming looser, so first they become aggressive, then they lose from the others. So all the tumor cells are stick to each other. They are stick to each other like this. With the help of E-cadherin. With the help of E-cadherin and complementary adhesive molecules. So we have to lose them. So if you want to loosen, for example, I want to loosen this cell from all of this. So in this cell, I have to do the loss of E-cadherin and loss of CAM. If loss of E-cadherin and loss of CAM is there, so this cell will loosen from that. Okay? Now this will loosen. Now after that, it will interact with the extracellular matrix. So first it will interact with the extracellular matrix. This is already loosened. You can see this cell. Consider of red cells. So this is already loosened. Now it is interacting with the ECM, and after that it is degrading. So first it will interact with the ECM and then degrade the ECM and activate the ECM. So you can see this the looser tumor cell is entering inside the ECM. So first a clone of tumor cell become aggressive, then it will loosen, then it will interact with the ECM and degrade and anchor and penetrate the ECM. So interact with the ECM and degrade the ECM. You can see the two things here. Okay, 4 are done. Okay, now after that, these tumor cells which are loosened, which are aggressive, they have already degraded the ECM, they will enter in the blood vessel. They will enter in one of the lumen of the blood vessel. But once they will enter in the blood vessel, the lymphocytes, the lymphocytes will kill them because it's small enough. So why not definitely kill them? Because they're very small. The tumor cells cover themselves with RBC so that WBC cannot attack them. So first they enter the blood vessel, and after entering they will cover themselves. They will cover themselves. You can see they are covering themselves with the RBCs at the platelet. They are forming a thrombus so that the WBC cannot attack them. So first they enter the blood vessel and they cover themselves with the RBC platelet and they form thrombus. After that they move to some other side. They are moving, and after moving to some other side they extravasate. They come out. Here they were entering. Here they are coming out. Here the entry is there. Here the exit is there. Exit is extravasating from other side. They are entering here. They are moving here. They are entering extravasating at some other side. And after that they form a growth and at some other side. So these are the 8 steps. First imagine, visualize the 8 steps. The first thing, a clone of the primary tumor becomes highly active. A clone of the primary tumor becomes highly active. A clone of that. After that it will loosen from the other tumor. So after losing it interact with ECM. And after interacting with ECM it degrades ECM and penetrates. After that it enters in blood. And it will form a thrombus that will enter the muscle within. Okay? So they will form a thrombus. They will move to some other side, they will flow and they will extravasate. They will extravasate on the other side and they will grow and form secondary at some other side. So last step they will form the secondary, they will form secondary at some other side. So these are the 8 steps. Now I will show you a video which all these steps. If I tell you watch the video, please tell me here. So first thing you can see, this is the primary tumor cell in which of becomes active. Maybe a bone becomes aggressive and it is penetrating in the ECM. far away. At some other far away point, that extrovert will form. And it goes and that it is at multiple portions of multiple portions. From one primary multiple portions. I will tell you more instance. Because these are in a body. So the first step, a clone become high levels. So high levels clone is tumor and from a population of monoclonal tumor cells, some population of high tumor cells, and that is known as a So from all the tumor cells, you can see all from all these primary tumor cells, a population, a subpopulation of high aggregate and a high Second step, this high aggregate growth will result from all these primary tumor cells, a population, a subpopulation of high aggregate and a high Second step, this high aggregate growth will result from all. So you can see this is a primary tumor. Tumor cells are adhered to each other within the that is each aggregate of So if you want to loosen this from all other, you have to use each aggregate and cap with this cell. If this cell is losing the each aggregate and losing the cap, it will get looser. So these two are like the block, the fuse, the fuse. So the fuse aggregate, if the fuse drops, it will loosen. Now again, so third step, so you can see the first this clone become aggregate here and it will become aggregate and aggregate. Now it will interact with ECM and penetrate the ECM. Third step is interaction. How to interact with ECM is receptors one. ECM is extrovert. So it is having receptors for actin, fibrinogen, bindocaptin, collagen, because ECM is made up of all this. So this is the composition of ECM, it is having receptor for all these. So it is interacting and after that it is debilitating. ECM is made up of collagen, so it is having collagenase. ECM is made up of gelatin, so it is having gelatinase. So basically it is having macroproteins. That macroprotein is under help to degrade the ECM and manipulate the cytokines. It is manipulating in the ECM with the help of enzyme collagenase, gelatinase, macroproteinase like that. And after that you can see it degrading. See, it is degrading the ECM and antibiotics. It is degrading. After that it will do the entry of the tumor cell into the blood vessel. You see the tumor cell, see this point. The tumor cells are entering into the blood vessel. Tumor cells have food, they are working and how does they do? So they have a pattern which is known as autocrine motility pattern. Because of which the tumor cells are moving, it is a receptor mediated motility. They don't have food. It is a receptor mediated motility which is diverted towards the blood vessel. You see. So first they are penetrating, degrading the ECM and after that see the blood vessel. This is the blood vessel. They are moving. This motion is due to autocrine motility pattern. And after that they form a tumor. They cover that. They don't have food. It is a receptor mediated food. So they have a blood vessel. You see the tumor cells, see this point. The tumor cells are entering into the blood vessel. Tumors don't have food, they are working and how does they do? So they have a pattern which is known as autocrine motility pattern. Because of which the tumor cells are moving, it is a receptor mediated motility. They don't have food. It is a receptor mediated motility which is diverted towards the blood. You see. So first they are penetrating, degrading the ECM and after they see the blood vessel. This is the blood vessel. They are moving. This motion is due to autocrine motility pattern. And after that they form a tumor. They cover that cell. The tumor cell cover that cell with the RBC and platelets so that the RBC will not affect them. Tumor cells cover themselves with the circulating blood cells so that they form a tumor. So that the RBC do not do the improvement of all. They are very smart. So they cover themselves with RBC so the RBC cannot affect them. Now finally they form the tumors, they move to some other side. At the other side they do extravasation. So they are moving to some other side. Got the point? So they are moving to some other side from away from the primary side. And at that side it is doing the extravasation. It is coming out of the endothelium, it is extravasating out. And after that, with the help of the growth factors, it is doing the unlimited, uncontrolled mitosis and forming the secondary. It is forming the secondary. So these are the 8 steps. It is coming out at some other side and growing like that. So at some other side, it is coming out, extravasating, and it is moving, it is growing and forming the secondary. So all the 8 steps at the tip of your tongue. Can you enumerate? 3, 4, 5, 6,